All right, here we are with chapter 34, and this is part 1 of 2 over face and neck trauma. So when it comes to faces and necks, it's not unusual for us to see people get injured in those areas. They're actually quite vulnerable to trauma, so lots of soft tissue, and oftentimes we lead with our heads when we get into trouble. Of course, these types of injuries can be some of the most visually shocking that we'll encounter. So it's really important to remember not to get too fixated on these injuries, because if you do, it can really lead you to miss some other more life-threatening problems that are going on. So don't get too distracted by these facial injuries. Of course, anytime we got airway compromise and that kind of stuff, they're gonna distract us, and we're gonna get a little fixated on them. So. All right, so let's do a little review, a little anatomy and physiology review. So remember, the face is structured by 14 facial bones. These include nasal, ethmoid, vomer, maxilla, parietal bone, frontal bone, sphenoid, temporal, lacrimal, zygomatic, which is around the eyes, middle and inferior nasal conch, and the mandible. Because the face is highly vascular, the soft tissue injuries that happen here can lead to a significant amount of bleeding anytime the face is involved. The orbits, or the eye sockets, are made up of 7 thin bones that help reduce the overall weight of the head. Because they are thin and delicate, the orbits are vulnerable to injury. A strong enough force to the eye can cause a blowout fracture, breaking the thin bones of the orbit. The eye is susceptible to many kinds of injuries, such as impalements, burns, and foreign objects. Eye movement is controlled by the extraocular muscles, which are directed by several cranial nerves. The ocular motor, which is the third cranial nerve, moves the eyes and the eyelids, and also causes the pupils to constrict and the lens of the eye to focus. The optic nerve, on the other hand, doesn't control movement, but it's responsible for your sense of vision. When you assess an eye injury, you should look at the sclera, the cornea, the conjunctiva, the iris, and the pupil. So all of it, or as much of it as you can see. With additional training, you might actually be able to use an ophthalmoscope and look more closely at the retina at the back of the eye. The ear is divided into 3 parts. We have the external ear, the middle ear, and the inner ear. The external ear, of course, that's going to be the fleshy part of the outside of the ear and the very entrance of the auditory canal. The middle ear is just inside of the fleshy part of the ear. It contains the tympanic membrane and the 3 small bones known as the malleus, the incus, and the stapes. The inner ear is comprised of semicircular canals, the oval window, the vestibular nerve, cochlear nerve, the cochlea, the vestibule, round window, and the eustachian tube. So we get into the middle ear, or the inner ear, it contains a whole lot more things. The difference is when there's an infection in the outer ear, it does not quite as bad. One on the inner ear is typically going to affect balance and coordination issues. Paramedics typically treat injuries to the external ear. While injuries to the middle ear may be visible, they're usually difficult to treat, and especially outside of the hospital setting. There's just not much we can do for those in the field, and they're typically not a life-threatening thing to where that we need to worry about doing a whole lot with that. A normal adult has about 32 permanent teeth, and that's if they still have all their teeth, which are held in by the bony sockets called alveoli. Teeth can become dislodged during a forceful injury to the face, and a loose tooth can be a life-threatening airway obstruction if it winds up going down the throat. You should know the different types of teeth and their parts, which include the crown, the cusp, the pulp, and the dentin. And we can see all those here in that picture on your screen. The main structures in the front of the neck include the thyroid and cricoid cartilages, the trachea, and the many muscles and nerves, and along with a few vessels that kind of sneak in there on the sides as well. The main of these blood vessels are the internal and external carotid arteries and the internal and external jugular veins. The vertebral arteries run along the sides of the cervical vertebrae in the back of the neck, and injury to any of these major blood vessels can lead to cerebral hypoxia and infarction and air embolism and even permanent neurological damage. Other important structures to know in this area include the vagus nerve, the thoracic duct, esophagus, thyroid, parathyroid glands, lower cranial nerves, brachial plexus, soft tissue and fascia, and various muscle groups are going to be along in here as well. A lot going on in the neck area, so a lot of problems can arise and a lot of major blood loss can happen in that area. So, all right, let's move on to patient assessment. First, when you start with any patient assessment or anything like that, we're all obviously going to do a scene size up and make sure that the scene is safe for ourselves, our patient, our partners and bystanders and other responders. Before you approach, you need to be sure and follow those standard precautions like wearing gloves and a mask and eye protection. You should then determine how many patients there are and whether you need to call for additional specialized help. Be sure to evaluate the mechanism of injury and maintain a high suspicion for all possible injuries. When responding to serious trauma, you can use the XABCDE approach if you see life-threatening external bleeding. As part of your general impression, you must quickly determine if there is any immediate threats to the patient's life. Always check for responsiveness, even if a soft tissue head injury seems minor. As you approach the patient, listen for any unusual respiratory sounds. You might hear some sonorous sounds, which sound like snoring. This often indicates that the tongue is obstructing the airway because the position that they're laying in and they're not controlling their airway. There could be gurgling respirations that suggest that there is fluid such as blood or secretions in the airway that may need to be suctioned. The oropharynx can become blocked by the tongue, secretions, blood, vomit, foreign bodies, and even an improperly inserted airway, as well as loose dentures, can become a compromise to breathing. As soon as you get the patient to the patient's side, you need to assess their breathing. If you suspect a neck or spine injury, have another crew member hold the head still while you check the airway. Keep the head manually stabilized until you've confirmed that spinal precautions aren't needed. If they are, maintain that immobilization until full spinal precautions have been put in place. For patients who are unresponsive or have an altered level of consciousness, you should consider using an airway adjunct. If the patient's airway is blocked by blood, vomit, or other substances, immediately suction the airway or roll the patient onto their side to clear it if spinal issues are not suspected. You must assess the patient's breathing and its effectiveness. Take corrective action as needed. Carefully look for signs of hypoxia. If you can, monitor the patient's oxygen saturation and keep it above 94% with supplemental oxygen. You should also assess for and treat any other life-threatening injuries that it could potentially affect the patient's breathing. When assessing circulation, check the patient's pulse for its presence, make sure that they have one, the rate, regularity, and quality. You should also look at the patient's skin color, temperature, and check moisture. You must control any visible signs of bleeding, and then reevaluate the patient's mental status and their response to stimuli, noting any changes since your initial contact with them. Check each extremity for a pulse, check motor function, and check sensory function. Ask the patient if they're experiencing any numbness or tingling in their extremities, and make sure you directly observe the back for any penetrating trauma and carefully palpate the spinal column for any deformity, step-offs, point tenderness, or crepitus. Patients with abnormal physiological signs should be transported immediately. Interventions that can be done while en route to the hospital should be postponed until after you've addressed the immediate life threats. For patients with isolated injuries, it's often better to manage those injuries carefully while still at the scene. You should find out if there was a medical reason that may have contributed to the patient's trauma. Ask the patient, their family, or bystanders for important information about the injury, such as whether the patient was wearing a seat belt, or if the airbag deployed, maybe how fast the vehicle was going, or how far the patient fell, if they lost consciousness, or what type of weapon was used. Record this information on the patient care record and share it with the hospital staff when you arrive with the patient at the hospital. If the patient is unresponsive and there's no one to provide a history, you can gather information by looking at the scene and checking for any medical alert jewelry. Sometimes there may not be time to perform a secondary assessment, but in other cases it can be done on the way to the hospital. Use the techniques of inspection and palpation. You're going to be looking for drainage from the ears and nose, noting if it's bloody or clear. Also look for periorbital ecchymosis, which is bruising around the eyes or bruising behind the ears. When assessing the face, you should look for asymmetry in the eyes, ears, and skull, and check for the patient's ability to smile. Be on the lookout for any deformity, soft tissue injuries, lumps, or hemorrhaging on the head and neck. Also check the ear openings for any swelling, occlusion, or asymmetrical narrowing. Inspect the mouth for lacerations, bite marks, and missing teeth. And finally, look for any evidence of dehydration. For additional assessment, check the position and condition of the uvula, the posterior pharynx, the mouth, oral mucosa, teeth, gums, and tongue. Evaluate the patient's gaze, noting if it is focused, distant, or conjugate, meaning both of the eyes move together, or disconjugate, where the eyes don't move together. Be sure to ask the patient if they are experiencing any visual disturbances like diplopia or double vision. Observe the position and color of the eyes, looking for any signs of trauma or infection. Assess the pupils for direct and indirect pupillary responses, and check for extraocular movements, and look for any signs of nystagmus. Assess the patient's visual fields for any defects like hemorrhage, which is a visual field loss on the left side or the right side. Inspect the neck for jugular vein distension and feel for any enlarged lymph nodes. When you palpate the face and neck, ask the patient to tell you if they feel any pain or tenderness. While palpating, you should check for any deformities, bony instability, lumps, or depressions in the skull. Also feel for any soft tissue injuries that might be hidden by hair. Be sure to check for bony instability of the face, the mandible, and the temporomandibular joint. Note any enlarged or tender lymph nodes of the neck, and finally check for a tracheal deviation of the neck, because this could be an indication that the trachea has been pushed to one side due to an issue in the chest cavity. Reassess your patient frequently while you're on the way to the hospital. For a stable patient, you can reassess them every 15 minutes. For the more serious patient, you should reassess them every 5 minutes. Be sure to get and evaluate vital signs and check all of your interventions, recheck all of your interventions, and monitor the patient's condition. You should also repeat the primary survey as part of your reassessment process. Your documentation should include a description of the mechanism of injury, the position you found the patient in, the location and description of their injuries, and an accurate account of treatment that you provided. And for patients with open injuries and severe bleeding, you should estimate and report how much blood you believe was lost. The emergency care of face and neck injuries must always prioritize protecting the patient's airway. Frequently assess your bandages, and if blood soaks through them, use additional methods to control bleeding. You should also expose wounds, control any bleeding, and be prepared to treat for shock. Always evaluate patients with major closed soft tissue injuries to see if they need supplemental oxygen to maintain a saturation level of 94% or higher. All right. So, let's talk about the pathophysiology of facial injuries a little bit here. Open soft tissue injuries to the face can be an indicator of more serious injuries deeper within the head. Massive soft tissue injuries can easily compromise a patient's airway, and with any closed soft tissue injuries to the face, you should always have a high index of suspicion for underlying issues. Impaled objects in the face pose a high risk for compromising the airway, and then massive bleeding to the oropharynx can cause airway obstruction, aspiration, and even ventilatory inadequacy. The ingestion of blood is a problem because it is a gastric irritant and it can lead to vomiting, which will increase the likelihood of aspiration. Maxillofacial fractures happen when the facial bones absorb a lot of force from an impact. The same forces that cause facial fractures are likely to cause traumatic brain injuries and cervical spine injuries. So you must also protect a patient's cervical spine during your assessment. You should monitor the patient's neurological signs, especially their level of consciousness. The first sign of a maxillofacial fracture is often ecchymosis, and you should also be suspicious if you see a deep laceration to the face. Common signs and symptoms of maxillofacial fractures include ecchymosis, swelling, pain, crepitus, dental malocclusions, facial deformalities, asymmetry, bone instability, impaired eye movement, and visual disturbances. Nasal fractures are identified by swelling, tenderness, and crepitus to the nose. They are often complicated by a nosebleed and can be difficult to control and may compromise the airway. Mandibular fractures and dislocations usually result from significant blunt force impact to the lower third of the face. The mandible is often fractured in more than one place, making it unstable to palpation. You should inspect the mandibular joint in patients with a history of blunt force trauma to this area who show dental malocclusion, numbness to the chin, or an inability to open their mouth. Other findings can include swelling, echinosis over the fracture site, and partially or completely avulsed teeth. You can identify injuries that a patient might not report by palpating the mandible for point tenderness and pain on motion. Temporal mandibular joint dislocations are most often caused by excessive yawning or opening of the mouth too wide. Patients with temporal mandibular joint dislocation typically feel a pop, and then they will be unable to close their mouth. Maxillary fractures are most often caused by significant blunt force injuries to the face. This type of fracture can produce massive facial swelling, instability of the mid-facial bones, malocclusion, and a characteristic elongated appearance of the face. Lefort fractures are broken into four categories. A Lefort-1 fracture is a horizontal break of the maxilla that separates the hard palate and the lower maxilla from the rest of the skull. A Lefort-2 fracture is a pyramid-shaped fracture that involves the nasal bone and the lower maxilla. A Lefort-3 fracture is a break of all the midfacial bones that separates the entire midface from the cranium. And lastly, a Lefort-4 fracture is a Lefort-3 fracture that also includes a fracture of the frontal bone. The type of Lefort fracture can vary depending on the side of the face and whether the impact occurred and how the force was distributed. You should look for any cerebrospinal fluid leaking from the patient's nose, which may indicate an open skull fracture. An orbital blowout fracture involves the bones on the floor of the eye socket. These fractures are typically caused by a fist, a dashboard, or a baseball striking the eyes and surrounding soft tissues. The patient might report diplopia or double vision and could have reduced sensation above the eyebrow or over the cheek. Signs and symptoms include infraorbital hyposthesia, which is a reduced sensation in the areas served by the infraorbital nerve. Other signs are epithalamus trimicticus, or the eyeball sinking back into the orbit. Massive drainage may be present too, which may contain cerebral spinal fluid. There could be impaired vision and paralysis of an upward gaze, which occurs with fractures of the inferior orbit. The extraocular muscles can become trapped, which stimulates the oculocardiac reflex, a response that decreases the heart rate by more than 20%. The patient can experience bradycardia and even asystole due to this reflex. The treatment for isolated orbital fracture is mainly supportive. If the eye has been ruptured, you should place a rigid eye shield over the injured eye and bandage both eyes. Zygomatic fractures are often caused by blunt force trauma to the face. Signs and symptoms include a flattened appearance to the face, loss of sensation over the cheek, nose, and upper lip, and paralysis with an upward gaze. These fractures are often associated with orbital fractures, other ocular injuries, and epistaxis, which is a profuse nosebleed. So typically these are not isolated fractures. There's some other fractures that kind of go along with them. It is difficult to fully assess the facial region without an X-ray capabilities. So your assessment of these patients is going to primarily be clinical, and you're going to go off of index of suspicion. You'll rely on what you can see and feel rather than the diagnostic equipment that the hospitals will use. When assessing the face, pay close attention to any swelling, deformity, instability, and blood loss, because these are going to be key indicators of what may lie beneath. You should evaluate the patient's cranial nerve function. Visually inspect the oral pharynx for signs of a posterior nosebleed. A sign of a posterior nosebleed is frank blood trickling down the back of the throat, even after a simple anterior nosebleed has been controlled. Be sure to alert the emergency department of this situation, because this can become a problem rather quickly. You must protect the cervical spine. Open the airway using the jaw thrust maneuver while a team member holds the head in the neutral position. If the patient reports severe pain or discomfort from movement, immobilize the head and neck in the position that you found them. Inspect the mouth for any objects that could block the airway and remove them, then suction the oral pharynx as needed. Insert an airway adjunct as needed. It is extremely important not to insert a nasopharyngeal airway in a patient with suspected nasal fracture, cerebral spinal fluid leaking from the nose or blood leaking from the nose, or if there's any evidence of mid-face trauma, unless it is absolutely necessary, because it was really easy for those airway or nasal adjuncts, nasopharyngeal airways, to make a turn and go the wrong way, and they can actually slip through a fracture in the base of the skull. You must assess the patient's breathing and intervene as needed. If the patient is breathing on their own, administer oxygen as necessary. For patients who are breathing adequately, you should use a bag valve mask, or breathing inadequately, use a bag valve mask to ventilate with 100% oxygen. Your goal is to maintain an oxygen saturation level of 94% or higher. We're not looking for 100. You should perform endotracheal intubation on patients with facial trauma to protect the airway from aspiration and ensure adequate oxygenation and ventilation. It's important to maintain inline stabilization during this intubation procedure, so you may have to enlist some assistance to help hold the head in line, keep everything in line. If endotracheal intubation is too difficult or impossible, you may need to perform a surgical or needle crike. Of course, foreign bodies in the throat can cause airway obstructions and aspiration, so it's critical to keep the patient calm and properly positioned, and you should transport them in a position of comfort whenever possible. You should treat facial lacerations and avulsions the same as any other soft tissue injuries. Control the bleeding with direct pressure and apply sterile gauze. Leave any impaled objects in the face unless they pose an immediate threat to the airway. If you must remove an object from the cheek, do it carefully, preferably pulling it out the same direction that it entered. As you remove it, pack the inside of the cheek with sterile gauze and apply counter pressure from the inside. If bleeding continues, position the patient on their side to help facilitate the drainage of blood from the mouth while a team member maintains cervical spine stabilization. For severe bleeding in the oropharynx with inadequate breathing, you should suction the airway for 15 seconds and then provide ventilatory assistance for 2 minutes and then repeat the process. The best way to control a nosebleed is by applying direct pressure to the nostrils. Some EMS agencies also permit the use of nasal sprays, but that's really protocol dependent. If the patient is responsive and you don't suspect a spinal injury, instruct them to sit up and lean forward as you pinch their nostrils together. An unresponsive patient should be positioned on their side. For a responsive patient immobilized on a backboard, consider a drug-assisted intubation if needed. You must carefully assess the patient for signs of hemorrhagic shock because it is entirely possible for a nosebleed to bleed such a large volume of blood that it begins to become problematic and it impacts them systemically. You can use cold compress to help minimize swelling and reduce pain from maxillofacial fractures. However, don't apply a cold compress directly to the eye if you suspect an orbital fracture or an eye injury. Applying pressure to the eye could increase interocular pressure and may stimulate the oculocardiac reflex, as well as cause further damage to the eye. All right, so let's take a look at eye injuries. Compression to the eye from lacerations, foreign bodies, or impaled objects can interfere with the blood supply and cause a loss of vision. This pressure can also squeeze the vitreous humor, iris, lens, or retina out of the eye, causing irreparable damage. Foreign objects on the surface of the eye can cause severe irritation, leading to conjunctivitis, where the conjunctiva becomes red and inflamed. The eye attempts to flush out the object by producing tears. Corneal abrasions can also result from superficial trauma to the cornea or an object being stuck in the eye. The irritation is often made worse by bright lights, and especially rubbing the eye. Most foreign objects can be flushed out of the eye easily. However, rust and metal cannot be flushed out of the eye and must be removed by a physician. Dust, dirt, splinters, and other particles are common causes of eye injuries, often entering the eye during work and recreational activities. Blunt eye injuries can range from minor swelling to bruising, and also as ecchymosis to a complete rupture of the eyeball. Hyphemia is bleeding into the eye's anterior chamber that obscures vision. And 8-ball hyphemia is a dark colored clot that completely covers the anterior chamber. An acute injury causes bright red blood to collect, while dark blood suggests an older injury. To visualize the hyphemia, shine a pin light at an angle through the anterior chamber. The light will exaggerate the height of the blood, making it easier to tell the difference between blood in the chamber and blood in the corneal surface. A patient with hyphemia will often report photophobia, pain, and blurred vision. If a patient has an altered level of consciousness, you should suspect a head injury and treat them accordingly, because head injuries and eye injuries oftentimes go together. A retinal detachment is the separation of the inner layers of the retina from the choroid, which is the underlying layer. This is a painless condition that can cause the patient to see flashing lights, specks, floaters, or a cloud or shade over their vision. A retinal detachment requires urgent medical attention to prevent permanent vision loss. A central retinal artery occlusion is caused by a blockage in the retinal artery, which can lead to ischemia and necrosis of the retina if the blood flow isn't restored quickly. This can cause permanent vision loss. Patients with this condition are typically in their 60s, are more likely to be male, and complain of sudden, painless loss of vision. A central retinal vein occlusion is the cause of sudden vision loss in patients over 50. It's usually caused by thrombosis or a blood clot and is described as a sudden onset of a painless, blurry, and distorted vision in one eye. Chemicals, heat, and light can burn the eye's delicate tissues and the surrounding structures, often causing permanent damage. Chemical burns require immediate emergency care and are usually caused by acid or alkali solutions. A patient will typically have vision loss and may show evidence of facial skin burns. An acid burn can cause immediate damage to the corneal epithelium and make the cornea appear kind of white or opaque in color. Alkali burns are even more dangerous because they can rapidly pass into the anterior chamber of the eye and damage the iris. You should immediately flush the eye with water or sterile saline solution if you suspect either acid or alkali has come in contact with the eye. If a sterile solution isn't available, just use whatever clean water that you have available to be able to do that. Thermal burns to the eyes occur when a patient's face is burned during a fire. It's not too uncommon for those to happen. Infrared rays, eclipse light, and laser burns can cause significant permanent damage to the eye's sensory cells, but these retinal injuries are not usually painful. Ultraviolet rays can cause superficial burns to the eye that may not be painful at first, but can become painful about 3 to 5 hours later. These burns usually lead to severe conjunctivitis with redness, swelling, photophobia, and the feeling of a foreign object in the eye, and excessive tearing. This is also what we see, the ultraviolet rays is also what we see with welders or with someone not using the proper eye protection, that's using a cutting torch or a welder or something like that, causes a burn to the eye. You should begin your assessment by noting the mechanism of injury, then ensure the patient has patent airway and is breathing adequately. Be sure to control any external bleeding. If it's appropriate, perform a rapid full body scan. When taking the patient's history, you should ask a series of questions including how and when did the injury happen? When did the symptoms begin, and what symptoms is the patient experiencing? You should ask if both eyes were affected and if the patient has any underlying eye conditions or diseases. Finally, ask if the patient is taking any medication and if they have any other systemic conditions that we need to be aware of. Symptoms of a serious eye injury include, of course, vision loss that doesn't improve with blinking, which may indicate damage to the eye or the optic nerve. Double vision usually points to trauma involving the extraocular muscles. Other symptoms of severe eye pain and the sensation of a foreign body may be present as well. You should begin with a thorough examination to determine the full extent of the damage. Check if the eye can move with the 6 cardinal positions of gaze: right up, right down, left up, left down. You should also check for pupil dilation to light and the peripheral vision. During your physical exam, you need to evaluate each of the eye's structures and their function. Check the orbital rim for ecchymosis, swelling, lacerations, and tenderness. Look at the eyeballs for ecchymosis, swelling, and lacerations. Check the corneas for any foreign bodies. And finally, check the conjunctiva for redness, pus, inflammation, or the presence of any foreign bodies. Check the eyeballs themselves for redness, abnormal pigmentation, and lacerations. Assess the pupils for size, shape, equality, and their reaction to light. Check the patient's eye movements in all directions for any paralysis of gaze or discoordination between the two eyes. To check visual acuity, see if the patient can read a newspaper or a handheld visual acuity chart. While eye injuries are not usually life-threatening, they should still be evaluated by a physician or an ophthalmologist. For lacerations and blunt trauma to the eye, you should control any bleeding and gently patch the eye before transporting the patient to the hospital. Bleeding can usually be controlled with gentle manual pressure. It is extremely important not to apply pressure directly to the eyeball itself, because this could cause permanent vision loss. To look for corneal abrasion or a foreign body, you should examine the eye by turning the upper and lower eyelids inside out. You may be able to remove a foreign body with irrigation. A topical anesthetic can alleviate some of the symptoms of a corneal abrasion, and a lubricant can resolve some of the pain. However, it's unlikely that you're going to have any of these available in the field, and whether or not your protocol would allow you to use them. You may need to cover both of the patient's eyes to prevent a sympathetic eye movement. Injuries, especially those involving metal fragments, may need to be examined under a special microscope at the hospital before they can be removed. Most injuries to the globe are best treated in the emergency department. In the field, a rigid eye shield is typically all that is needed. When treating a penetrating eye injury, you must never put pressure or manipulate the injured eyeball. If the part of the eye is exposed, gently apply moist, sterile dressing to prevent it from drying out. Cover the injured eye with the appropriate eye shield or a cup and a sterile dressing. Apply soft dressings to both eyes and transport promptly to the hospital. If you suspect hyperemia or ruptured eyeball, you should take spinal motion restriction precautions as well. To decrease intraocular pressure, you should elevate the head of the back guard by about 40 degrees if possible. If there are no other contraindications, transport the patient in the Fowler position. Both of the patient's eyes should be covered. If the eye is avulsed or displaced out of its socket, do not attempt to manipulate or reposition it. Instead, cover the eye with the most moist, sterile dressing. You should also stabilize the other eye to prevent further injury from a sympathetic eye movement. Place the patient in a supine position and transport them to the hospital immediately. You should carefully evaluate the entire eye with a light and note any blood or discoloration of the sclera. If a foreign object is on the surface of the eyelid, you may be able to remove it with a moist, sterile cotton-tipped applicator. Never attempt to remove an object that is embedded in the cornea or is on the eye itself. To help dislodge a foreign object, you can irrigate the eye with sterile saline solution. If a foreign object is impaled in the eye, don't attempt to remove it at all. Instead, stabilize the object and cover the eye with a moist, sterile dressing. Or you can place a cup or other protective barrier over the object and secure it in place with a bulky dressing. You must cover the unaffected eye to prevent further damage from sympathetic eye movement and transport the patient immediately to the hospital. For eye burns caused by ultraviolet light, cover the eye with a sterile moist pad and an eye shield. You can lightly apply a cool compress over the eye if the patient is in extreme distress, and then transport them in a supine position. For chemical burns to the eye, you must immediately begin irritating with sterile water or a saline solution. You should never use a chemical antidote in the eyes. Ideally, use a device like a Morgan lens to irrigate the eye. If only one eye is affected, be careful not to let the contaminated water get into the unaffected eye. Irrigate for at least 5 minutes. But for burns caused by alkali or a strong acid, you should irrigate continuously for 20 or more minutes. Here's some examples of some effective ways that we can irrigate the eye. Sometimes the eyes have been getting irrigated prior to our arrival at the scene, and if that's the case, you need to make sure that you note that as well. So you should continue irrigating the eye while you're on your way to the hospital, and be sure to control any runoff to prevent further contamination. Your local protocol is going to guide you on any specialized treatments for eye burns. And that is the end of part 1 to facial injuries. Face and neck injuries. In the next section, we'll get into a little bit more about the neck, and we'll finish out the face, the mouth and the face and all that kind of stuff. And we will be done. All right, see you back in part 2.